Welcome. If you're gearing up for your PEBC MCQ exam, you know hepatitis questions can be pretty tricky. So today, we're going to demystify acute viral hepatitis. We'll break down all the must-know clinical pearls, from diagnosis all the way to treatment, so you can walk into that exam feeling confident. So let's dive right in. Here's our roadmap. We're going to follow the clinical path, right? Starting with the basics of the viruses themselves, then we'll get into how we diagnose and manage them. We'll also spend some quality time on the super important considerations for pregnant patients before we wrap it all up with key prevention strategies and those therapeutic tips you'll definitely want for your exam. Okay, first things first, we have to build a solid foundation. What exactly is acute viral hepatitis, and who are these 5 main viral culprits we're actually dealing with? The key definition to lock in your brain is all about the timeline. Acute viral hepatitis is a systemic infection, and the magic number is less than 6 months. That's how long the symptoms and the virus are present. And as the name implies, the virus loves to target the liver, causing all that inflammation and cell death that drives the disease. Now, this table breaks down the essential differences, and it's fantastic. Notice the transmission routes, right? Hepatitis A and E are fecal-oral, but B, C, and D, they're mainly bloodborne or transmitted sexually. Now, the most critical column for your exam is that last one, chronic risk. Just remember, hepatitis A never becomes chronic, ever. Meanwhile, hepatitis C has a crazy high chance, we're talking up to 80%, of sticking around and becoming a chronic infection. This really visualizes that key difference. You know, acute infections are usually pretty loud. The patient feels sick, they have a fever, jaundice, which makes the diagnosis a bit more obvious. But chronic infections, oh, they're the silent killers. They can hang around for years, sometimes decades, without any clear symptoms, just quietly causing damage that can lead to cirrhosis and even liver cancer. So now that we know the culprits, how do we actually diagnose an infection? How do we properly assess the patient? Let's take a look at the signs. Before we jump into specific tests or treatments, it is absolutely crucial to understand our goals. What are we trying to do here? We're not just trying to zap the virus, we're also trying to prevent it from spreading, calm down that immediate liver inflammation, and most importantly, stop the disease from turning into a chronic problem, or in the worst case scenario, acute liver failure. Think of this flowchart as your clinical decision-making map. It all starts with a patient who comes in with a viral-like illness, and their liver enzymes are all over the place. The very first step is to check their liver function. We look at INR and bilirubin. From there, we check the serologies for the different viruses, and those results guide us down specific pathways for diagnosis and management. That whole flowchart really relies on one thing: being able to correctly interpret those serological markers. This is the absolute key to getting a definitive diagnosis, so let's break them down for each virus one by one. For hepatitis A, thankfully, it's pretty straightforward. If you see IgM antibodies, you are looking at an acute, current infection. Simple as that. Now, if you see IgG, that means the person is immune, either because they had it in the past or they got vaccinated. Okay, pay close attention here because this is a classic exam topic. For hepatitis B, the surface antigen, or HBsAg, tells you there's an active infection. The surface antibody, anti-HBs, means immunity. But the real tiebreaker is the core antibody, anti-HBc. And here's the pearl. If a patient is immune from the vaccine, they will be anti-HBc negative. If they're immune because they had a past infection that they cleared, they will be anti-HBc positive. You absolutely must know that distinction. For the other viruses, the key takeaway for each CV is that a positive antibody test just means exposure. That's it. You have to confirm an active, ongoing infection by testing for the HCV RNA. And for HDV, just remember it's kind of a freeloader. It's a defective virus, so you only even bother testing for it if the patient is already positive for hepatitis B surface antigen. Okay, we've nailed down the diagnosis. What's our initial game plan? For most cases of acute viral hepatitis, the very first step is all about supportive care. These supportive measures are the foundation of treatment. The absolute #1 priority is to protect that already inflamed liver from any more insults. That means counseling the patient to avoid alcohol completely. And, this is critical, it means we as pharmacists need to do a thorough medication review to find and stop any drugs that could be toxic to the liver. Now, if the liver's ability to make things, its synthetic function, starts to fail, and we see that with a rising INR above 1.5, we have to act fast. We give vitamin K to help with clotting, and if there are signs of full-blown liver failure, like confusion or encephalopathy, that's a medical emergency. They need an urgent referral to a transplant center. So let's move on to the specifics.
While supportive care is key, some cases do require targeted antiviral therapy. So, which ones are they?
This is a really important clinical question for hepatitis B, and the answer isn't a simple yes or no. It's exactly the kind of scenario you need to be ready for on the exam. For most healthy adults, the answer is a clear no. We don't treat. Over 95% of them will clear an acute HBV infection all on their own. We only start treatment if the infection takes a severe turn, which we define by an INR climbing over 1.5 or the development of acute liver failure. In those very specific cases, we use oral antivirals. Oh, and a key point. PEG interferon alpha is absolutely contraindicated in this setting.
For acute hepatitis C, the story is completely different. You gotta flip your thinking. Here, spontaneous clearance is pretty low, but the success rate of our direct-acting antivirals, or DAS, is unbelievably high. Because of this, the guidelines have changed. Now we recommend treating immediately, as soon as you diagnose it. We don't wait around to see if the patient clears it on their own. All right, let's turn to a really high-stakes scenario, managing viral hepatitis in pregnant patients. This requires a lot of special consideration for both the parent and the infant. For hepatitis A and C, management during pregnancy is mainly supportive. There's no specific antiviral treatment we give during the pregnancy itself. For HCV, we just defer treatment until after the delivery. The main goal is just to monitor for complications, like premature labor. For hepatitis B in pregnancy, this number is everything. You have to burn it into your brain, 200,000. If a pregnant patient's HBV DNA level goes above 200,000 international units per ml during their third trimester, we have to start antiviral therapy. Why? To dramatically reduce the risk of passing the virus to the baby. So when we do need to treat, we've got a few options, but tenofovir is often our preferred agent. And the reason is simple. It has a high genetic barrier to resistance, which is great, and it has a really robust safety profile that's been well documented in pregnancy registries. And here is a huge, critical safety alert for your exam. Entecavir is absolutely 100% contraindicated in pregnancy. This is all because of findings of teratogenicity in animal studies, which makes it a complete non-negotiable contraindication. Okay, let's wrap this all up with the best strategy of all, prevention, and then do a rapid-fire review of the most important takeaways from our entire explainer. Prevention really starts with what we do after someone's been exposed. For a person exposed to hepatitis A or B who doesn't have immunity, we can give them immunoglobulins. Think of this as giving them a temporary, borrowed shield. It provides immediate but short-term passive immunity to bridge the gap until their own immune system can kick in. But of course, the real cornerstone of prevention is active immunization. The hepatitis A and B vaccines are incredibly safe, super effective, and they provide long-lasting protection. In fact, universal vaccination programs for HBV have just dramatically slashed infection rates. All right, let's recap the most high-yield points for your exam. Seriously, if you can master these 6 concepts, you are going to be in fantastic shape. This covers everything from correctly reading HBV serology, knowing the INR threshold for treatment, the viral load threshold in pregnancy, and that absolute contraindication of entecavir. As you keep studying, always think about the patient in front of you. How might a co-infection with HIV, for example, or severe kidney problems alter these standard plans? That's where your clinical expertise really shines. Good luck.